Wonderful. All right, everybody. So I'm going to kick off our third Patient Safety Culture Survey Quality Improvement Series. How they've been working is to date we've already done 2. They're just quick 30-minute little webinars. And the first 2 webinars, how we're kind of structuring them is the first webinar was on handoffs and transitions, where I reviewed some case studies, did some research, and found an actual tool that was proven in case studies to improve the handoff and transitions domain within the patient safety culture. And then on the next webinar, it was a follow-up to that where we actually had a facility share how they have implemented and used SBAR in their facility. So this week, we're actually focusing on non-punitive response to error, where I'm going to share with you a tool that has been known and proven in case studies through ARC and IHI to improve the non-punitive response to error domain within the patient safety culture survey itself. And then following in 2 weeks on the next webinar, the idea is to have a facility share how they've implemented the tool that I'm going to present to you today and how they're using it in their facility and provide their feedback. So these webinars are actually going to take place every 2 weeks. They're always going to be on Thursdays. They're always going to be from 11:30 to 12. The conference line will remain the same every time. The only thing that unfortunately is going to change is the link. Through ReadyTalk, every time I schedule a conference, it creates a new link rather than let you use the same link. So just be on the lookout the week of a presentation. Save the date will go out that will have the link for that specific one. Otherwise, everything stays the exact same. So with that being said, I'm going to get started. So what I wanted to show you really fast is the 3 questions within the patient safety culture survey that were linked to the non-punitive response to error domain. If staff feel like their mistakes are held against them, when an event is reported, it feels like the person is being written up, not the problem. And then staff worry that mistakes that they make are kept in their personal file. So all of these 3 questions were directly linked to the non-punitive response to error domain. So today what I'm going to share with you is a tool or technique that helps build upon the next 3 slides that I'm going to talk to you about. It's all about obviously building a patient safety culture within your organization. It's having your pervasive commitment to patient safety. It's improvement in patient safety does not occur unless there is a pervasive commitment by your organization and a clearly defined and ongoing effort by everybody in the facility, from your leaders to your physicians to your coworkers. Commit to an environment in which coworkers and physicians feel free to contribute to building and maintaining a culture of safety by establishing a non-punitive, blame-free culture that encourages coworkers to focus on safety issues, identify and report all events, near misses, close calls, hazardous conditions, you name it, and help to develop and implement performance improvement processes across your organization. Taking the blame off of the people, but rather than finding out what's wrong with the processes and the systems, not the people. Of course, the success of this effort depends on each coworker's willingness to participate, to contribute, and to be open to sharing and receiving information about safety events and close calls. You know, you need to hold everybody accountable and expect and require that all your coworkers fully take part in building your hospital's culture of safety. So, sorry, I jumped the gun. What's a non-punitive, blame-free environment look like? What do we do? How do we get there? Well, first you have to work to develop a culture of patient safety that strongly encourages people to report adverse events, near misses, close calls without fearing what might happen to them. As obviously you can tell by the questions that are directly linked to this domain, that seems to be the topic at hand, that seems to be the worry behind event reporting. We need to have coworkers feel that they are full partners in the job of improving the safety of the patient care process and systems, that the organization's primary response to adverse events is to learn from them and not to assign blame or impose discipline. A culture of safety is where people are able and willing to report both adverse events and close calls without the fear of punishment, which will lead to a safer environment not only for patients but also the coworkers, the physicians, the visitors, the patients' families, and so on. So how do we get there? Well, the first step was to build a non-punitive policy on patient safety and reporting. A non-punitive policy on patient safety and reporting is designed to encourage coworkers to feel comfortable with reporting your adverse events and near misses, and it allows them to participate in improving processes and systems and taking the fear away from getting in trouble or placing blame. At the same time, however, it does acknowledge that individuals are responsible and accountable to patients, the public, and each other for doing whatever they can to make care safer. It helps to create a safe healing environment. Each individual is responsible for using sound judgment and being aware of potential hazards to patients before taking action. So not only does a non-punitive policy on patient safety help foster and encourage coworkers to feel comfortable reporting adverse events and near misses, and empowers them to participate in improving processes and systems, but it also creates accountability. So what I'm going to do now is there is a video from the Agency of Health and Research that I'm going to play. It's about 10 minutes, so it's going to take a chunk of our time, but I wouldn't share such a long video if I didn't think it was a great video. So what I'm going to do is share my desktop, so just bear with me 1 second. This worked out really well the last couple times I tried it, so it should go off without no problems. Okay, so here we go.
I have a beautiful blonde-haired, blue-eyed 9-year-old daughter who is quirky little girl, contagious, not funny, avid reader, and she was a blooming artist and an athlete, and she's no longer with me anymore. She died of medical errors. She got a hospital-acquired infection. She was a classic case of failure to rescue, where all the signs were there, and that she was deteriorating and no one could do anything.
At any one time, 1 in 25 hospitalized patients has a healthcare-associated infection, or HAI. About 75,000 hospital patients with HAI die during their hospitalization. In the case of Carol's daughter, Alyssa, the hospital's response was less than optimal.
She was in a teaching institution where the fear of hierarchy was there, and the residents didn't go up the chain of command. The organization where she died shut down on me. They wouldn't talk about what happened. They would not give me her medical records. It took the organization where she died 3 years, 7 months, and 28 days to have a conversation with me.
The current system doesn't work well for patients or providers or for people. When harm occurs, the strong tendency for hospitals to disclose as little as possible about what.
For Dr. Heather Farley, being forced into silence in another case made her question her ability as a healthcare provider and nearly ended her career as an emergency room physician.
I remember the day really clearly, even though it's several years ago now. I remember what she looked like. I remember the sound of her voice. She came in saying that she was having some palpitations. That's a very frequent complaint that we see in the emergency department. We did a full physical exam, and we put her on the monitor, and we did a whole bunch of blood work on her, EKG, X-ray, pretty thorough workup. And at the time that I saw her, she wasn't having any symptoms at the time. I discharged her, and I didn't think anything more about it until the next day.
The patient went into cardiac arrest on the drive home from the hospital. She was resuscitated and admitted to the intensive care unit.
I was sitting in my office, checking my email, and my administrative assistant called across the hall and said, "Hey, did you know that patient that you saw yesterday? She ended up coming back in." And my heart sank.
Dr. Farley's first instinct was to visit the patient in the ICU and talk with her family.
And everybody that I talked to said, I don't think it's a good idea if you talk to the family. And I just wanted to tell them what I knew, and because I knew that they were suffering and I knew they had questions, and I just wanted to reach out to them, but I never got the opportunity to talk to them, which is something that I regret to this day.
The patient later died in the hospital.
Several months later, I was notified that I was being sued. Just the first time that had happened in my career. I know that I'm a good person, and I care about my patients, and I work hard. And to have someone there accusing you of not caring, of being a bad physician, of being incompetent, it just strikes so deeply. Most emergency physicians have high percentage that are sued at some point in their career. I knew it was probably inevitable, but it doesn't make it any easier.
Traditionally, when harm has occurred, the first reaction is to deny responsibility and defend vigorously.
When we talk about deny and defend, we talk about a whole paradigm of responding to patient injuries or unanticipated clinical outcomes that has historically and literally for decades now been given over to the legal profession.
Culturally, we have several generations of physicians now who believe in patient autonomy and who believe in things like informed consent. If one should and under law must tell a patient about the risk of what might happen to them, don't you think we should tell patients about what actually did happen to them?
I had been 22 years in the trenches knowing that I had fought battles that I didn't need to be fighting. I was running up defense costs. I was dragging it out for a couple of years, and then we were settling cases on the courthouse steps.
Research funded by the Agency for Healthcare Research and Quality has shown that communication resolution programs can achieve some pretty remarkable results. Our funded grantee saw about a 50% reduction in claims and lawsuits, and big increases in satisfaction from both patients and providers. This program resulted in a 22% decline in malpractice premiums for the hospital and saved Medicare and Medicaid $3 million annually. It's very important both to try to figure out how to improve the process of what happens after harm occurs, and even more important, to try to figure out how to reduce harm to begin with. And it is clear from the evidence that we have generated that the implementation of communication resolution programs can be successful in achieving both of these goals.
Communication and optimal resolution process, or CANDOR.
The CANDOR process is a simple plan, and hospitals should have it ready to go whenever a patient is harmed during a stay. First, provide emotional first aid immediately to the patient, the family, and the caregiver, and maintain communications with them as your understanding of the cause of that harm grows. Learn to prevent similar events from happening in the future. And finally, make things right with the patient and explain what you're doing to ensure that care will be safer for future patients as a result of this experience.
The topic of resolution is integral to the entire idea of this model. Resolution is a proxy, and it's not always funny. It sometimes speaks to our
I apologize, guys. There's only a couple minutes left in the video. It's buffering.
credibility. It sometimes speaks to how earnest we are in terms of an apology. It tends to help people.
If it continues, we'll just cut the video off early.
Find justice in the whole approach. One of the misconceptions about the candor process is that it's just a big mea culpa every time something goes wrong. The real truth of this approach has little to
do with the malpractice part of it. It has everything to do with reconnecting a sense of accountability for the clinical outcomes that we have. At its core, it is literally as simple as saying we're not going to push things to lawyers when we haven't exhausted the notion that maybe there's a clinical explanation. Maybe this is way more important to the key mission of healthcare in general.
When patients have been harmed during a hospital stay, we can't always undo the harm that's occurred, but we can change the way we respond. Candor urges transparency from the beginning, teaching providers to be honest, to rebuild trust.
In every hospital system, there's at least three different parts to the equation of resolution. There's the folks in the trenches who have to deal on a very personal level with patient expectations, both for the sharing of information and at some point for compensation. But there's typically an insurance office or sometimes a commercial insurer, and then there's the legal office, the folks who have to pick up the pieces if the effort at pre-suit litigation doesn't work. In order to employ this model in a sensible way and in its most effective way, there must be trust between all three components.
I think our healthcare system is largely designed now, rightfully so, to continuously improve, and prompt and early communication certainly helps to do that. It reduces the worry, it reduces the concern of the patients and their families. We anticipate that this learning will continue and the program will evolve and will benefit from the experiences of certainly the medical professional liability community and all those they insure.
I think it is transformative for a healthcare organization. It engages the patient and the family early on. It doesn't regard error disclosure as a single event, but instead it opens a conversation.
The only way for an organization to learn is to show the failures and say, we are fallible, but we're going to learn about this, we're going to tell you about it, so that all of us together can make the system better.
The candor process is a wonderful entree to meaningful quality improvement, to healing the caregivers when bad things happen.
One error is too many, and its impact on the patient and loved ones can be devastating. Health professionals involved in an event that harms a patient often experience many emotions.
I was also so ashamed of what had happened and how I was feeling. One of the main pieces of candor is care for the caregiver. When I did finally tell my boss what I was dealing with, it was a very cathartic experience, and he was very, very supportive.
The implementation of these programs requires culture change. It requires a change in how people within the hospital identify errors, communicate errors. Our goal in this project is to create the tools and the infrastructure to allow a broad array of hospitals to be successful in implementing communication resolution programs. I think the most simple but powerful thing that I can say to people who are entertaining this idea but are afraid, don't be afraid. Don't forget why you came into healthcare, whether you're a lawyer or whether you're a doctor or a nurse in the trenches. Move forward in this approach with the confidence that the greater rewards will more than offset any fear that you have in trying. Start small, build confidence and build expertise in this space. The real truth is that this approach taps such basic human needs. And it works in Tokyo, it works in London, it works in Stockholm, and it will work everywhere in this country. Just don't be afraid.
Okay, so bear with me while I exit out of this and get back to the PowerPoint slides. Can you guys tell me, can somebody just chime in and let me know if you can see my slides?
It's Joanne, I can see them.
Awesome. Thank you, Joanne. Okay, so the whole purpose of me sharing that video was to talk about the communication and optimal resolution process, also known as CANDOR. The one thing that I want to point out is reflecting back on the 3 questions that are from the Patient Safety Culture Survey for the non-punitive response to error domain, was the fact that staff feel that their errors or events are going to be held against them, that it's going to stay in their record. So the one thing that I want to point out about the CANDOR process that they kind of said towards the end is that there is a component within it that talks about care for the caregiver, about creating the culture within your organization to let coworkers and physicians and nurses and everybody know that it's not something that's going to be held against them, that it's something that your organization wants to learn from to fix processes and systems that might be broken. And again, it's not always about adverse drug events. This tool is used for near misses, anything that could have potentially caused harm to the patient but never necessarily reached the patient. It's an entire process, of course, for you to use from start to finish if an adverse drug event occurs, but it's also a process and a tool that can be used to help implement and start a culture of patient safety in your organization. So the CANDOR process is a process that healthcare institutions and practitioners can use to respond in a timely, thorough, and just way when unexpected events cause patient harm. But it's also a great way to communicate with one another and internally if it didn't necessarily cause harm, but just for internal reporting where something might have almost happened that could have harmed the patient. This was based on expert input and lessons learned from the ARC's 23 million patient safety and medical liability grant that was launched back in 2009. And the CANDOR toolkit was tested and applied in an original 14 hospitals across 3 of the U.S. healthcare systems. But since then, as you know, we've used the Patient Safety Culture Survey that ARC has developed. And since they did that, they've actually taken that launch of just the original 14 and expanded it to the hundreds of hospitals that they have actually worked with the Patient Safety Culture Survey. And it doesn't just necessarily help this one domain, but as you know, there are a couple domains that are associated with event reporting. And this tool itself has actually shown to improve those couple of domains that are all about event reporting within the Patient Safety Culture Survey. So let me just... So one thing in the handouts that I sent, these should all be hyperlinked. The CANDOR toolkit contains 8 different modules, and what I love about it is that they each contain PowerPoint slides with facilitator notes, and some of the modules even contain tools, resources, and videos. It is a step-by-step how-to guide to create a patient safety, a culture of patient safety in your facility about event reporting. So there is an implementation guide, there's an overview, there's a module about obtaining organizational buy-in, there's another module that is about preparing for implementation, then it's all about event reporting, event investigation, analysis, and then response and disclosure. And then my favorite out of the whole packet is care for the caregiver, which helps whoever is involved in the event that occurred or the potential harm or the adverse drug event. There is a module that's specifically for them and is fostered for your coworkers that help them feel, I guess the word would be safe, to know that they can report it, to know that it's not going to be held against them, to know that it's not going to go on their personal record. From that, there's a resolution module, and then there's also an organizational learning and sustainability model. Each one of these modules, again, they provide PowerPoint slides, notes on how to go about using them, how to go from start to finish on implementation from the tools, the resources, and the videos that are provided. This next slide, it just kind of gives you an overview of how does CANDOR process work. Well, typically you identify an event, and that's the best way to start implementing it. Once you identify an event, then you go through the CANDOR system activation within the modules that I showed on the previous slide, and then you do the response and disclosure investigation analysis, and then you do the resolution. And those can circle back around until you come up with an improvement for the system or the process that might have been broken that led to an event potentially occurring or an event actually occurring. What will your facility learn by implementing and or using this process? There are a couple key learnings for hospitals who implement the candor process. It engages patients and family in disclosure communication following an adverse event. It helps you to implement a care for the caregiver program for providers and nurses and coworkers that are involved in any adverse type of event. It helps you to investigate and analyze any events to help you learn from it and prevent future events. It gives you a review and revise so that your organization's current process can align with the candor process itself. And then it helps you to establish a resolution process for your organization. So we all know humans make mistakes, to err is human. So by doing this and creating a non-punitive policy for patient safety reporting, it helps to encourage coworkers to report your events and close calls, and not to assign blame, but to learn what happened so that we can keep it from happening again. And one of the best ways to reduce any events is to take advantage of lessons present in close calls, where things almost go awry but no harm is done. Most mistakes occur as a result of an ineffective, improperly designed, or flawed system. As you know, most of us are dealing with new EHRs or switching from one EHR to another, and there are a plethora of things with those new implementations of EHRs. So that is just one of the many systems that could be potentially not working well for your facility that could be causing things to get missed. That's why, some of them are developing hard stops. I mean, the list goes on. But when coworkers report events and close calls, we are able to track them to find patterns and trends, which helps us learn how we can improve our systems to prevent future mistakes. So the candor process is all about trying to create that culture of patient safety and that care for the caregiver, and letting organization-wide coworkers, staff know that it's okay to report an event. It's not about you, it's about the systems and how can we make it better. So here on the screen I've included a couple more links. There is a link to the Candor Toolkit. So in case some of the hyperlinks on the previous slide for each one of the modules isn't working, there is a direct link for the Candor Toolkit. It will take you to the Agency of Health and Research Quality's website that is that page that has everything on the Candor Toolkit. Another one of my favorite books, of course, some facilities have this. It is obviously at a price, but again, there's a link to the Err is Human book, but there's also a great 8 to 10 page summary that's out on the ARC's website as well, where it provides about 10 pages a summary of the Err is Human book. And the great thing about that book is it's all about adverse drug events or preventing harm or almost misses or close calls, but it's not about putting blame on the healthcare providers. It's all about talking about the systems and the processes that could be faulty. It's not about assigning blame. It's all about it's a great book. I'm rattling on now, and we're getting close to time. So check it out. And finally, on the last slide, what I want to show you is this has been out a couple times, but it wasn't originally in a zip file, so we got quite a few bounce backs. What I wanted to show you, again, is that these Patient Safety Culture Quality Improvement Series are going to take place every 2 weeks, always on a Thursday, always from 11:30 to 12. The phone number will remain the same, but the link will change, unfortunately. So the week of the presentation, I saved the date just for that topic or that webinar will go out, and it'll have a specific link for that one at the very bottom. But the conference call number will always stay the same. But so this just shows you the dates from now pretty much to the end of the Flex Grant year. Of course, we might have one more at the very end of August, which is going to be a wrap-up of everything, where we might actually have some facilities come back and just do like 5 to 10 minute presentations across what they've been doing to date on the things that we're sharing on each domain. And then lastly, I just have our contact slide for myself, Rochelle, and Kyle. And before I let you go, I know we're about to run over, but I just wanted to let you know that the next presentation, which is going to take place on May 4th, we are going to have a facility actually talk about or share how they implemented the candor process, how they're using the candor process, and share kind of how they've gone about it. As I mentioned earlier, we are trying something new, and I would appreciate your feedback if this is not working. We wanted to do quick little 30-minute presentations as to not create webinar burnout. So when we first rolled this out, the first presentation was on handoff and transitions, where I provided a tool, which was SBAR, that has been proven in case studies to improve handoff and transition within the patient safety culture survey. Then the following week, we actually had a facility, Powell Valley, shared how they had implemented SBAR and used it in their facility. So this week, we're talking about non-punitive response to error. I'm sharing a tool with you, and on the next presentation, we are going to have a facility share how they've implemented this tool and how they're using it. The same with the remaining. The next one will be another topic where I will share a tool that has been proven to help with the patient safety culture improvement. And then the following will be a facility sharing how they've used that tool and implemented it in their facility, and so on until we get to August, where we'll be wrapping up and we'll be welcoming facilities back to share. With that being said, I'm going to let you get back to the rest of your day. But if you don't feel that this type of platform is working, I would love to hear from you and other ideas that you might have. Feel free to email me directly. And with that being said, I hope you guys have a great rest of the day, and thank you for joining.